Hello everybody. Today we are going to discuss a case of glaucoma associated with Sturge-Weber syndrome in a child managed by Ahmed glaucoma valve. An 11-year-old boy from Mizoram presented with glaucoma associated with Sturge-Weber syndrome in one eye. The other eye was normal. The BCVA was 618 N8. The intraocular pressure was 40 millimeter mercury on maximum medication. The disc showed pointed cup with thin rims. Fundus showed diffuse choroidal hemangioma involving the posterior pole, and the B scan showed diffuse choroidal thickening, as we can see here. So, because the IOP was high, we had to go for surgery. The dilemma was whether to go for a trab or whether to go for a tube. Because of the risk of suprachoroidal hemorrhage, we decided to go for Ahmed glaucoma valve, the pediatric implant FP8 under general anesthesia. We used preoperative IV mannitol, and we left viscoelastic in the AC to reduce postoperative hypotony. On postoperative day 1, despite all the precautions, the child presented with a flat antechamber. The vision was only PLPR. The tube was sandwiched between cornea and the iris, and the tip of the tube was barely visible. There was peripheral iridocorneal touch and central lens corneal touch. There was 360 degrees choroidal detachment. IOP was high. It was 30 millimeter mercury because the tip of the tube was occluded by the iris. We started conservative treatment with topical steroid antibiotic, atropine, tropicamide phenylephrine, dorzolamide timolol, and oral steroids. On postoperative day 2, the picture remained almost same. There was persistence of the flat anterior chamber, choroidal detachment, and now we're thinking whether we need AC reformation. But on the postoperative day 5, the AC started deepening spontaneously, as you can see in the photo, and the choroidals gradually started resolving. On postoperative day 15, the vision had improved to 636, the AC was well formed, the AGV plate and tube were okay, the intraocular pressure had come down to 16 millimeter mercury without any anti-glaucoma medication, and the choroidals had resolved. So the take-home message from this case was, postoperative shallow AC can occur after AGV in Sturge-Weber syndrome, even after taking adequate precautions. In our case, even a flat antechamber with extensive choroidals normalized with conservative management alone. The points to ponder in glaucoma in Sturge-Weber syndrome are, number 1, whether to go for a trab or a tube. Both have their merits and demerits. Number 2, whether to go for a prophylactic sclerotomy and the technique for this, which has been described in the literature. Number 3, whether to go for a valved or a non-valved implant. And number 4, even if you are using a valved implant, whether we can use a vicryl suture to reduce the hypotony. Thank you for your kind attention.